and then we can start with our presentation. So welcome to our short webinar on transfusing wisely. It's sure to be a good session today. We've got lots of experts here to get through your burning queries. So normal webinar procedure, we'll have about 45 minutes worth of presentation and then 15 minutes for Q&A at the end. We'll try and get through all of your questions if we can. Please pop those questions in the Q&A box. Please don't use the chat facility. I don't think it's available for you anyway. So if you type your questions in there, we'll either get through them live in the session or our experts may be able to type a query, a question for you. May be able to type an answer there for you before the end of the session. If we can't get to your question and you do really want an answer, please do email us at the short inbox and then we'll try and get a response for you when possible. So I think that's probably about time. We can probably get on with the presentation. So we've got a wonderful panel joining us today. We've actually got representation from all the 4 blood services, as well as some patient blood management experts and some laboratory experts as well. So we're honoured to be joined by Dr. Paul and Bolton Banks, Dr. Catherine Booth, Dr. Andrew Charlton, Dr. Damien Carson, Dr. Edwin Massey, Dr. Katie Hans, Anne Davidson, Amy Baird, Dr. Jennifer Davies and Dr. Shruti Nariam. You've also got your shop team members here as well, providing the assistance. I won't have time to go through all the affiliations, but we'll just leave those on the screen for 1 second for you to be able to read through. Lovely. Hopefully you got all those details. So outline of the session today, we're going to provide some insights from shots regarding avoidable transfusions and key learning points to do with these. We're going to have updates from all the UK countries on transfusing wisely. And as mentioned, we're going to finish with our Q&A. So without further ado, I'm going to pass on along to Dr. Paula Bolton-Maggs, and she's going to go through her section of the presentation on avoidable transfusions.
Thank you very much. I'm going to address a couple of causes of avoidable transfusions, that is hematinic deficiencies and then inappropriate use of group O negative blood. Can you click through the slide? Thanks. People who are particularly at risk, that's women of childbearing age and people with GI problems, should be screened actually because they're often iron deficient and it's good to treat that rather than miss it. Next, please. So we're going to look at 6 years of data from SHOT, during which we found 63 cases of avoidable transfusions for hematinic deficiencies. And most of those had no transfusion-associated circulatory overload, but some of them did, and I'll come back to that because a patient actually died. You'll notice that iron deficiency was responsible for nearly 80% of the reports, B12 deficiency and folate less common, and there were some with combined deficiencies. But in nearly 70% of patients, the hemoglobin was above 50 grams per litre with no evidence of bleeding or cardiac compromise, but the patient still needed a transfusion. Next, please. So red cells were transfused in most of the patients, but there was one where the patient got everything, and I'll come back to that in a minute. Where patients developed TACO, there was variable data about whether they used a checklist. And of course, we do recommend that people have a checklist used for TACO prior to transfusion because that may avoid some. In 98%, the patients fully recovered, but a couple needed transfer to the HDU. And as I said, one died. So it is important not to transfuse people who really don't need it. Thanks. Here's an illustrative case, a woman in her 30s who was pale, but not symptomatic, but with an impressively low hemoglobin, was admitted, and the hematology registrar was asked to review and said, look at the high MCV, check the hematinics and don't transfuse. But unfortunately, a trainee panicked and activated the major hemorrhage protocol, and then the patient received totally inappropriately 4 units of red cells, 2 of FFP and 1 of platelets. And in fact, the folate before transfusion was 1.6, which is severe deficiency, and that was available within 12 hours of admission, so they certainly could have waited. Next, please. This was a woman in her 50s with iron deficiency anemia and quite a low hemoglobin, but she was only tired. She was 54 kilograms and then was prescribed a 5-unit transfusion by a junior doctor, and she received all of those with a full blood count only after the last unit. She at least should have had a check blood counts after 1 or 2 units rather than giving her all 5. Next. So our key recommendations is that patients are reviewed with low hemoglobin to see whether it might be a hematinic deficiency and treat them appropriately. watch the trend in the hemoglobin level and particularly look at the MCV because the clues are there. It's low in iron deficiency and raised in B12 or folate deficiency. We don't want to waste blood components, and inappropriate use can cause significant risks, as I've discussed. Transfusion decisions must be individualized. Thanks. When we look at the use of emergency group O negative red cells, I give you some background there. 8% of the population are OD negative, but 13% of red cell requests from hospitals are for this. You can give OD positive red cells to adult males over 18 and women over 50, as long as they're not on regular transfusion regimens. So let's look and see what's happened. So we had a retrospective look over an 8-year period to see how many we could find. Next. And we found 203 cases of avoidable transfusion of emergency O-negs. In 65%, the recipient was an adult man or a woman over 50 years of age, so they could have received O-pos. And in 94 patients, there were fully cross-matched or type-specific units available that they could have had. Next. So emergency OD negs could have been avoided in 40% where there were blood sampling errors, as poor communication, incorrect units, and so on. Attention to detail. Acute bleeding was the indication in the majority of patients, but in some patients, it wasn't. So O-negs are a precious resource and should only be used where necessary. Cross-matched or group-specific are preferable, and O-negs are not safe for all patients. So all hospitals should be reviewing their transfusion policies and practices for the use of OD neg cells. And please look at how you use OD pos for emergencies. Thanks. I'll now hand over to Andrew Charlton.
Thanks very much, Paula. So my remit today is to look at avoidable O-neg use and transfusions in hematinic deficiency, and from a perspective of the English Blood Service and also what's happening to try and reduce those in England. So let's look at O-negative first. The last NCA, which was in 2018, showed that there was actually a decreasing number of O-negative units going to O-negative patients. So whereas in the prior audit in 2010, 70% of OD negative cells that were available were given to OD negative patients. This has fallen to 59% in 2018. Now, that doesn't necessarily mean that they didn't go in incorrectly, but it's just an important pointer for us to note that less O negative goes into O negative patients now, and we obviously need to be mindful of that as we're considering how it's used in our hospitals and in our units. In that audit, 16% of those units were used in emergency packs, and of those, 10% were transfused in an emergency to either males or to women of non-childbearing age. And as we know, it's considered really best practice now that in those situations, OD positive can be used. So what are we doing about this? And I'm really going to point you towards a very small number of activities of the whole that are available. And these have all been produced and worked on by many different people who are part of the team. So I want to give acknowledgement to all those who've been responsible for that. But I'm going to point you towards some of them. And this is the patient blood management section of the NHSBT Hospitals and Science website, and it has absolutely bucket loads of great resources to help hospitals, teams, clinical areas and laboratories think about how they're using OD negative. And you can see here the the OD negative red cell toolkit available under the PBM section. If we move on, I'm going to show you some of the things. So actually the toolkit itself is made up of some stuff that has been developed by the NHSBT PBM team, and then a lot of it is signposting towards resources that are fantastic and are available for us to use. So you can see at the top left-hand corner there, if we could just pause for a second, the NBTC statement on appropriate use of group OD negative red cells. That's really helpful because you've got a sort of hospital facing rather than NHSBT facing statement about the safety of the use of OD positive cells in emergencies in particular. So for RTCs, HTCs, hospital transfusion teams that are worried or concerned about using O positive in emergencies, you can find really helpful directions in that document. Blood Education is a podcast. So this is just one example of podcast you can pick up. This is by Susie and Helen at Birmingham. If you've not listened to some of their podcasts in transfusion, they're a fantastic resource. And there's a great one there about how OD OD negative should be used and why it's important to use it appropriately. The bottom right hand corner there tells us about, it's only got about K positive and K negative. This is actually in the context of OD negative red cells. So this is a resource drawn up by the NHSBT PBM team itself, and is again guidance that's really helpful for laboratories and for clinicians. SHOT itself has produced a really helpful guidance about when OD negative can be used, and you can find that on their website and also linked to in the toolkit. This is a great example of an RTC produced guideline. This is basically a top tips guideline produced by the East of England RTC, and it's fantastic. There are loads of things on there for clinical teams. There's stuff for labs, there's stuff for TPs, there's stuff about stock holding and how you can optimize that. So and it's been reproduced with permission, and there's a link there to get to it. So again, this is hospital facing best practice that's been shared essentially. We've also got permission on that website to share exemplar documents from individual hospitals, and this is from Guy's St Thomas's, and it's a really helpful, this is emergency use of OD negative. You can see at the bottom there's actually a flow sheet about, which samples have you got, what does it confirm about the group, and again, this is freely available for people to look at, adopt, and to edit as you choose. There are some infographics in the toolkit, and these are really helpful if you're thinking about things like screensavers, or you're wanting to promote a particular initiative that you're doing in your hospital. NHSBT PBM have produced some of these great infographics that are really helpful to use. And then the Blood Stocks Management Service have also produced things looking mainly at the laboratory element of things around how much stock we hold, and that we know that poor stock holding does increase the risk of inappropriate use of OD negative. The issuable stock index is sent to hospitals with their hospital reports and helps people to understand how much stock they're holding and whether they can reduce it. And you can see here there are also BSMS education days that that they run, and there's currently some running at the moment. And again, it's a fantastic resource that's available mainly for laboratory staff to go to, but also TPs and others who are involved in transfusion. Thanks. So other activities, we've got the MBTC recommendations. There are RTC resources, audits and surveys available, and the monthly hospital reports that go to your hospital do actually have OD negative information on them. From NHSBT's point of view, there's much work to be done, and we know that we need to increase the donor base. We know that we need to reduce substitutions, and you will see that depending on what sort of size of hospital you work in, you will see that there are either small to larger percentages of substitutions that are given to you, and therefore increase the amount of O negative that you have in stock and make it harder for you not to inappropriately use it. So we are aware of that, and I think one of the areas that NHSBT is trying to work hard on at the moment is thinking about where we have confirmed groups in the past and then RCI do grouping and find that they can't confirm it, can we avoid OD negative use in that situation, or D negative use in that situation, because we know that that's a problem that we do see frequently and that labs often feed back to us about. So what about transfused hematinic deficiency? This is something that we've already heard about through Paula's presentation, but we last audited physician use of red cells at the end of 2019, and that report was published at the beginning of this year or end of last year. And importantly showed this, that of medical patients, the final cause of anemia was considered to be iron deficiency in 20% of medical patients. Now that doesn't mean that's how they presented, but at the end of the admission, someone decided that was probably iron deficiency anemia. Now, there are of course lots of reasons why people with iron deficiency anemia might be transfused appropriately, but what we decided to do with these figures was say, well, how many of these people presented with bleeding? And it was about a third of them. So we took those out and thought, well, 2/3 of these people are presenting with iron deficiency anemia, but not with a bleeding phenotype. And so clearly we're trying to avoid transfusion in those situations if at all possible. The median hemoglobin of these transfused iron deficient non-bleeding patients was 70 grams per litre, which I did check several times. Seems amazing because that's obviously right on the threshold of our NICE guideline. But obviously to have a median hemoglobin of 70, that means you've got an awful lot of people with a hemoglobin over 70 being transfused in this situation. And indeed, a quarter of these people reported either no symptoms or only mild or sort of non-specific symptoms. 30% of them had a hemoglobin between 70 and 90, and 14% had a hemoglobin of over 90. This is non-bleeding iron deficiency patients with no or mild symptoms. And so clearly there's work for us to do there. B12 and folate deficiency rarely presents acutely requiring transfusion, and you can see in the case that Paula highlighted, there was someone presented with a hemoglobin as low as, I think it was 30, who was not in extremis and could have safely waited for supplementation. We found about 4.5% of medical patients were receiving red cells purely because of B12 and folate deficiency. And that represents, in England alone, somewhere between 32 and 40,000 red cell units a year. So clearly, this is something which where trusts need to look at their own cases in this audit and decide, did these really need to be transfused? What actions have we got? Well, I'm going to show you now the tip of the iceberg in terms of things you could look at for ways of avoiding transfusing hematinic deficiency, and most of them obviously center around iron deficiency. This is the recently published Centre for Perioperative Care guidance, which essentially pulls together lots of different guidance about management of anemia in the perioperative setting, which is obviously not the setting we've just looked at in the audit with regards to medical patients, but it does give a great flow chart to try and avoid iron deficiency in the perioperative setting by treating it early. We've also got obviously the NICE blood transfusion guidelines, and then a year later the quality standards, which include quality standards around iron deficiency and supplementation. There's the Choosing Wisely, which obviously this seminar is named after, standards as well about not transfusing red cells in iron deficiency without hemodynamic instability. There's now Sequin, which many of you will be aware of. Hospitals don't have to choose this Sequin, but many of them have done. And that's around anemia screening and use of iron supplementation. This is part of the package drawn up by the NHSBT PBM team. Again, there's lots of resources available on our PBM website with regards to supplementing iron and preoperative anemia. This audit itself was presented, I managed to present this at the Society of Acute Medicine Conference, which is obviously full of physicians, acute physicians in particular. So we were able to highlight it in the audience that we really want, which is obviously people who are using it in that setting. And then finally, it's also going to be presented at the Royal College Patient Safety Committee very shortly. So there's plenty of actions that we're trying to use in order to try and reduce inappropriate use in hematinic deficiency. And finally, some blood transfusion data is making its way onto Model Health and is already there, indeed, including the NICE quality standard audit, which you can find and point your hospitals to right now. So with that, I'm going to hand over to Damien.
That's great. Thanks, Andrew. Hi, everyone. I'm Damien Carson, and I'll spend the next 7 minutes telling you about our experience of reducing red cell transfusion in Northern Ireland. So 83% of all transfusions in Northern Ireland are actually given to patients over 50 years old. And population data indicates that this age group is where our population is growing. And I would imagine this is much the same across the rest of the UK. For ourselves, it's approximately 1.83% per year of this group that are the most heavily transfused. Next slide. And so this should translate to an underlying demand increase of about 1.6% per year, just because of the shifting age and the population numbers. The orange dotted line of predicted use in Northern Ireland indicates where we might now be expected to transfuse over 80,000 units per year. However, the blue line indicates our actual use, which is less than 40,000, indicating that our blood management activity is associated with over a 50% decrease in the predicted use of red cells per head in the population. Next. This previous success in demand control can teach us a lot about where to look for additional success in the future. We're really big believers, as I'm sure everyone is, that good data informs good decisions, and we've carried out many local studies in Northern Ireland with data relevant to our local clinicians that they really can take in themselves. These two studies are perhaps the most influential, and between them identified, first of all, significant numbers of inappropriate transfusion, a very large amount of overtransfusion, that is given too much blood, and very poor management of anemia. We've heard this from the previous speakers. These are common threads throughout the UK. And together, these causes resulted in many transfusions that should not have occurred. So once the data identified where our problems lay and the underlying deficiencies causing them, we were able to create many initiatives to correct the problem. And in all, there's been over 25 separate red cells initiatives in Northern Ireland since 2003. And you'll read down through this list, and this will be very common across the whole of the UK. We're all doing the same sort of work. Next slide. But what I'll thanks you. What I'll bring to your attention, however, is the timeline of the effect of these initiatives. And you'll see from the timeline that there's just no single quick fix or single initiative to improve transfusion practice, but rather this gradual effect of these marginal gains as different initiatives cumulatively influence individuals to an increase in effect over time. Next. It's worth highlighting during this period that the Northern Ireland Transfusion Committee, or the NITC, which is the key driver behind all of our regional initiatives, became inactive for an 18-month period due to a funding issue. And this led to a loss of regional leadership and communication, an interruption of all the regular regional meetings that we had with all the HTCs and the trusts, and a total cessation of all new red cell initiatives. And unsurprisingly, the demand for red cells stopped going down and then started to actually increase for the first time ever. Next. Subsequent allocation of resource led to resumption of our normal NITC activity. The work, the communication, the meetings all restarted along with a wealth of new initiatives. The red cell use gradually began creeping downwards once again. And we believe that this illustrates that patient blood management is effectively, it's a change management process that needs leadership, organisation, and a constant stream of fresh initiatives to evolve successfully. Next. So where might Northern Ireland future reduce red cell demand? Well, we have to again look at this previous data. We know 85% of all our transfused patients in Northern Ireland are anemic on admission to hospital, and that much transfusion is avoidable by treating the anemia appropriately, by identifying high-risk groups, investigating their underlying hematinic deficiency, and then treating the deficiencies appropriately. So that's great, thanks. It's important that we invest a resource where we can get the best return on the reduction of the red cell use. So over the last 15 years, while both medicine and surgery have reduced the use, the main reduction has actually been in surgery. And as much more blood is currently administered in medical specialties in Northern Ireland, we plan for an increased focus on the improved management of medical anemia and not just surgical patient blood management, because that's now where we think we're going to get the biggest return. So last slide, thanks. So just a final slide then on our future strategy where we're going to go in Northern Ireland. First, I've discussed the importance of data to direct our decision-making and the choice of effective initiatives, and we've recently secured current resource for this. And so we're going to be continuing to do our audits and initiatives across the region. Secondly, we have a new regional digitalisation of all hospital notes project coming into Northern Ireland, and we see huge opportunity for it to both facilitate live transfusion data and to be constructed in such a manner to influence clinical transfusion behaviour. And once again, we're heavily invested into this to try and make this work. And finally, despite these enormous gains that we've achieved over the last 15 years, making us an extremely restrictive transfusion area, we can see further potential by the greatly improved treatment of anemia, initially in the community, and then also within the hospital environment for both medical and surgery patients. We believe, first of all, that community anemia practitioners in every trust could work in the community, advising GPs, practice nurses, patient groups, outpatients, and locally associated groups that would have an interest in optimising the identification, investigation, and treatment of anemia. Likewise, in the hospital settings, we've identified there should be sessional time for both medical and surgical anemia leads to allow them champion once again, the identification, investigation, and treatment of anemia with all the professionals, the clinics and the areas that deal with anemic patients within the hospital. We believe this coordinated approach to the management of anemia and the control of both the initiation and the volume of transfusion can further reduce transfusion exposure in all our patients. Thank you very much, and I'm now handing you over to Edwin Massey.
Thanks. I'll try not to repeat too much of what's been covered already. Look, I've put in some more broad overview of patient blood management, transfusing wisely measures in Wales. In Wales, we have a Blood Health National Oversight Group, a national group similar to the National Blood Transfusion Committees in other nations, where all healthcare providers provide support. Now, this group has had really good engagement and close collaboration between the blood provider, those looking after patients, transfusion laboratories right across the country. And I think that collaboration has been key in making advances across the country. We have a blood health plan, which we work to, and we report via the Welsh Government through the Chief Medical Officer. There are several working groups. Next slide, please. A key working group following on from today's discussion is the OD negative group. Guidance was produced previously and updated in 2021. And I think one of the real drivers that works very well is having performance indicators. So in particular, looking at OD negative as a percentage of total issues and then also having so that's circulated along with other parameters on a monthly basis. And we can see the data for the whole country, and then we can also see the data for every health board. So if I'm in Cwmtaf Morgannwg Health Board, I can see my own data, and I can see that of the other health boards such as Nairn and Bevan, Cardiff and Vale, etc. So we can compare ourselves with peers, and if we feel we're not doing as well as we could, then it's a real driver to improve. And this was commenced during the pandemic and has been a really useful driver to improvement. Similarly, in platelets, a care pathway has been produced, and their performance indicators, the main one there being relating to wastage. And I think the initiative that perhaps is most pertinent, as discussed on the previous slide, is preoperative anemia. The pathway has been produced and agreed nationally, which we'll come on to shortly. We also have an intraoperative cell salvage work stream, so that's the 4 main work streams, and that was more recently added and is being developed. As you know, you may well know that in Wales, the consumables for intraoperative cell salvage are provided centrally, and we have a process for monitoring that. So we're currently having a bit of a move to improve our data collection and update it, so we can really look at performance on that. And we have some other subgroups, such as the Serious Hazards of Transfusion group, chaired by Joe Longford and Betsy Cadwallader, who look at safety issues particularly pertinent to Wales. Next slide, please. So this is the pathway, I'm not sure how clearly it projects, but this is the pathway that's been agreed across Wales for preoperative assessment. Funding's been provided by the Welsh Government, so the progress with this will be monitored. It's been supported by some project management staff and nursing support at various health board sites, which we will be rolling out in the near future. So it's been partially implemented, and that additional support will now to be fully implemented and monitored. The reflex testing has been put in place on the national IT system. So if an EDTA sample and a clotted sample are sent, they will automatically trigger tests. If anemia is detected, then the ferritin will be tested and TSATs. And similarly, moving on from that, depending on the findings, and if there's a raised MCV, further tests will be performed and actions undertaken. So very much looking forward to this being further embedded and greater enabled by the IT support across Wales over the next 2 years. Next slide, please. This is an example of the peer performance that goes around. This is the All Wales data for red cell wastage. And in the documents that exist with this in, the next page will be in alphabetic. It'll be Nairn and Bevan Health Board, then Cardiff and Vale, then Cwmtaf, etc. But you can go down, you can look at how Wales is performing, you can look at your own health board, and you can look at further health boards. So that's just an example of what we use as a way of peer performance monitoring. Next slide, please. Applications. One of the things during the recent shortages, amongst the advice given across Wales to try and transfuse even more wisely than people have been, was to download the app. I understand from Anne, who helps mastermind these apps, that there was a change in this, due to some change in the software. The data from the end of October 21 changed to that to the beginning of 22, but there has been an increase in uptake of the app. And it's difficult for us to measure what has actually changed leading to the red cell usage reduction that we've seen. But measures such as increased use of the indication codes and the blood assist app, more the indication codes will be, we believe must have contributed. Moving on to the next slide. So success, I mean, the graph doesn't look that drastic, and surprisingly, so during the period of the what we call blue alert in Wales, it's called pre-amber in other countries, so we'll probably align that. But during the period of blue alert, we put out notices and we escalated those. And we hope, you know, those were sort of gave sort of clear actions for people to take, such as to use the apps. And I note that during the Amber Alert that occurred in England more recently, there's again some very clear messaging went out using multiple routes to send that out through the RC Path shot and the British Society.
Not sure if Edwin has lost connection. Edwin, you still there? Okay, so if he comes back, then I think if we go on to Katie.
Thanks, Shruti. So I'll now try and give you a bit of a picture of what's happening in Scotland and focus on a few projects which have been undertaken over recent years in this field. So next slide. Firstly, just to set the scene about transfusion in Scotland. So we have about a tenth of the population of England and therefore transfuse about a tenth of the components. And these components are issued by SMBTS to 28 Scottish blood banks. And you can see on the map there, some of those are pretty far flung on the islands and so on, which can bring its own challenges. Transfusion practice is supported by the SMBTS transfusion team, which comprises transfusion practitioners who are employed by SMBTS but based in the health boards, as well as the clinical lead and senior nurse. And wherever possible, the transfusion team takes a Once for Scotland approach. So this has recently been demonstrated by the introduction of a national transfusion record, which has been implemented in 13 of the 15 Scottish health boards. And a bit like we've heard from the other blood services, Scotland has a wealth of data to support practice. And one that I'll mention just briefly is the Blood Bank Dashboard, which allows blood banks to have access to all sorts of data about their own blood wastage as well as usage, and has specific pages about things like O negative blood, non-homologous transfusion and so on. So all of that data is available to them to allow to support good practice. Thanks. Next slide. So a recent project undertaken by the SMBTS transfusion team was a national audit aiming to look at what was happening in Scotland in terms of transfusion to patients with iron deficiency anemia. And this used some of the data sources mentioned on the first slide. So patient level transfusion data from the account for blood was linked with hospital coding data. So identifying patients who had received transfusions during an episode of care which had been coded as an episode of care with iron deficiency. And this initial analysis identified just over 2,000 patients who'd been transfused about 6,500 units of red cells while diagnosed with iron deficiency. And that actually accounted for just over 5% of all red cells that were transfused that year in Scotland. The proportion of iron deficient patients who received a transfusion varied quite widely across the country, but averaged 27%. A subset of these transfused patients were then looked at further, just really to try and help understand exactly why they had received transfusion. So case notes were reviewed for, as I say, a 20% sample, and the highlights from that review are shown there. So most patients did have tests which confirmed iron deficiency. The majority of patients did receive iron, either oral, IV or both, but there was a small proportion who received no iron therapy despite having that diagnosis of iron deficiency. where a cause was identified, GI blood loss was the most common. And in just about half of patients, there was no documented evidence of a discussion with the patient about the benefits, risks, or alternatives to transfusion. So again, indicating room for improvement there. When we looked at the reasons given or reasons documented for transfusion, so about 15% were transfused within guidance. So those were patients who were either hemodynamically unstable or who had not responded to iron therapy. The majority of patients had a documented justification for transfusion, so a reason was noted, and that was most commonly that they were symptomatic of their anemia. But there was a proportion of patients who were transfused where there was no justification. So all in all, a report was put together and issued along with recommendations, and initially this was kind of caught up in the midst of the pandemic. So this was reissued to hospital transfusion committees in July 2022. And alongside that, a new KPI report has also been developed, which will be issued quarterly. And this gives hospitals and boards a KPI of 20%, so aiming to transfuse fewer than 20% of patients with iron deficiency anemia, and will allow them to monitor the impact of any interventions that have been made as a result of the audit and recommendations. Next slide, please. The second recent project was one looking at emergency O-negative blood. So this was an extension to a previous project which had been done, a quality improvement project looking more broadly at O-negative blood use. And this was done via a questionnaire, which asked questions regarding things like O-negative stock holding, where emergency O-negative blood was held. Was it held in satellite fridges? Was it held, in a hospital with a blood bank? Also about clinical things like the number of massive hemorrhage protocol activations. So we could try and get a real feel for how emergency blood was being used in Scotland. And also, was it being used for pre-hospital care? So this questionnaire was returned and gave us a really good picture of what was happening. We were able to identify that the specification of emergency blood varied from site to site, with sites with blood banks tending to hold higher spec units, so perhaps having O-negative blood which was also CMV negative or irradiated, for example, as their emergency units. We were able to identify that stock rotation and repatriation of these emergency O-negative units is happening in some sites, so that's to try and avoid wastage. And certainly where those stock rotations are taking place, there tended to be less in the way of O-negative time expiry wastage. And where it was in place, it tended to be done when there was still a week or two left before the units were due to expire. Encouragingly, about half of respondents had the use of OD positive emergency blood in their major hemorrhage protocol, so like we've heard earlier in the talk. And it was interesting to hear of some of the site-specific challenges. So these were things like perhaps blood banks who rely on ferries or even airplanes for resupply and the impact that has on their stock holding. So again, a report was issued with the recommendations which you see there. And the other thing which was included was some sort of case reports of good practice and things that had worked well, so that that learning could be shared and perhaps adopted by other sites as well. Next slide, please. The next thing to mention is a couple of Scottish Government initiatives which will impact upon transfusion. So the first is a national preoperative anemia programme, and this really started in 2018 with the development of this Scottish standard for optimisation of preoperative anemia. And to support the implementation of this standard, a Scottish Government programme of work was initiated, which has countrywide involvement with regular meetings and representation from each board. There's also a core data collection set and a toolkit and things for implementation. And this has all been relaunched again, following the pandemic, to support remobilisation and management of the backlog of surgical cases. Next slide. The next programme, which is worth a mention, not just for its good work, but also for its excellent acronym. So this is Pregnancy Anemia Management Scotland, or PRAMS. And this is a slightly newer programme of work, but really looking to address anemia in pregnancy. And again, with that Once for Scotland approach, so development of national processes for anemia detection in pregnancy, and really pushing oral iron therapy to try and reduce the number of anemic pregnant people at term, which has benefits both for mum and for baby, but also should result in reduced transfusion rates. And that is one of the measures being measured as part of the data collection. Next slide. And finally, just what's going to happen next. So these are projects that will be undertaken by the transfusion team. So appropriate use of blood, again, with a focus on medical blood use, as we've heard as one of the themes today. So really looking at what's going on there and starting with a gap analysis against the NICE transfusion guidelines there. A surgical blood use framework, which is more looking at the fact that the traditional maximum surgical blood ordering schedules are probably not so useful now. We're using lots of electronic release of blood, so trying to develop some contemporary guidance for preoperative assessment clinics about what samples and so on are required. And finally, the TACO and single unit transfusion campaign, which was launched at last week's joint SMBTC and SHOT meeting. Thank you. I'll hand back to Shruti.
Thanks very much, Katie. And this is just the last couple of slides to actually then say to optimize the learning from hemovigilance. Apart from the access to all the annual short reports and the chapters, what Paula was also actually referring to from the avoidable transfusions, the TACO chapter, we also actually then produce a lot of other resources as well. So all of these can be accessed under the current resources of the SHOT website. And like, for example, this A to E decision tree, which brings together all the PBM principles and building on what we have learned from the hemovigilance report. Now, equally, we heard from the speakers, especially what Katie was actually mentioning as well, about the consent for the transfusions. And we have like the NICE guidance as well as the SAPTO guidance document that is there for the consent before transfusions. We just have this in the last report. We actually also talked about what are the key aspects to be actually covered, building on what has been covered in these guidance. So this just actually acts as an aid memoir, and so that we are talking really about not just the risks and the benefits, but also actually talking about the alternatives as well that would need to be used. All of you may also be aware of the transfusion checklist. Again, that acts as more as a prompt about what is the indication for the transfusion, how much is actually needed, is it meeting the special requirement, all the specific requirements, and are the appropriate checks being done. Equally, we have heard about a case where the avoidable transfusion in a severe deficiency anemia resulting in the TACO. We have had deaths and major morbidity reported as well. And therefore, this pre-transfusion TACO risk assessment is a great mitigating measure. And please do make sure that this is incorporated as part of your pre-transfusion safety measurements. One of the main SHOT recommendations, and that has been there in the report this year, but also previously, we have actually then been encouraging the involvement, engagement, and empowerment of the patients. And this is not just in their own aspects of safety, but also in aspects of organizational safety as well. And so on the World Patient Safety Day, end of September, we have actually then also released a patient information page on the website. But this is actually a collaborative piece of work where all the transfusion related materials for patients developed by various stakeholders in the transfusion community are all collated on this webpage so that it is actually for easy access. And equally, we also have actually then developed an aid memoir for patients receiving blood transfusion. I know this may be difficult to read, but this is actually just to show you, if you use that QR code, you can then be accessing that web page, which also actually then encourages the patients to also actually then be actively getting involved, and we are partnering with them. Patient education, family education is also really, really important to ensure effective patient blood management. All resources from SHOT are available by the SHOT app, which is free to download on any smartphone. And, obviously the work that we do from SHOT is only possible due to the contributions of everybody involved in the transfusion community. So really a big thanks to all of you, and a message for all the hemovigilance reporters, please, don't forget to close all the possible reports by 29th of December, because that will then be included in the 2022 annual SHOT report. So that comes to the end of the presentation bit of it, and we can open up for question and answers. I'll stop sharing now.
Thank you very much, Shruti, and everybody. That was a really wonderful presentation, really useful. We've got loads of questions coming in. So firstly, I'm just going to cherry pick one. Because I'm the lab incident specialist that's generating a bit of discussion, and then maybe ask for maybe Amy's input on it as well. So somebody's asked how laboratory staff can support appropriate transfusion practice, and what lab staff should do if the request is clearly inappropriate. So we've had lots of really useful input there from Dr. Catherine Booth and Dr. Damien Carson, and Jenny's put a lovely answer there, but I was just wondering what Amy had any additional thoughts on that.
Yes, so I'm a big believer in empowering the BMS in the lab. And I think it's really important that the BMS does feel that they are in a position where they can challenge the request. Obviously, they would never be in a position where they would refuse outright to go ahead with the request, but they should certainly feel the ability to, especially with their understanding of what the guidelines are, to challenge any request that they felt was appropriate, and also refer that on to haematologists as well for support from haematologists if it was a genuine unsafe request being made.
Lovely.
Thanks very much. Got a question here that came in earlier, and I'll just read it out. It says the Royal College of Surgeons are suggesting benefits of using a second TXA dose for identified surgical patients. We have embedded this first. We embedded the first, but particularly in orthopedics, are now requesting a second dose. What are your views or evidence, please? I don't know if anyone wants to answer that one.
Any of the patient-facing consultants? I don't know, Andy, Kath, Damien, any of you? This is for tranexamic acid and for identified surgical patients. Second dose.
I'll just briefly say yes. I think the biggest job is actually getting everyone to do the first dose, because it certainly is very beneficial in orthopedics. And certainly there is evidence coming out that a second dose in some patients can be appropriate. I think the biggest challenge is actually getting the first dose in. For ourselves, we've had to make it part of the surgical checklist that the operation really can't proceed unless there's a very good reason why tranexamic acid can't be given. Yes, certainly in the bigger bleeders, yes, we have started to give a second dose ourselves.
I think the advice on 2 doses came particularly from the POISE trial, which was recently published, which really has, and that's the protocol they use, a dose at knife to skin and a dose at skin closure. And I think that amongst all the other years of evidence we have now are really reinforcing how effective tranexamic acid is and how safe.
Lovely, thank you very much. That's very interesting. It's new information. Another popular question that we've got here is: are organisations monitoring their uptake of IV iron, and if so, has there been an increase in usage as PBM measures become more ingrained? So I don't know who wants to, if we can get that from a PBM perspective or from the clinicians' perspectives.
I'm going to say that they might do. We don't have a national sort of rule that people have to monitor their IV iron use. Individual hospitals can certainly do it. It is a bit difficult because you can't always assume cause and effect with these things. And one example might be in the recent blood shortage, there was a lot of ordering of IV iron, but that doesn't mean there was a lot of administration of IV iron, so you have to measure the right thing. So we know that lots of people ordered loads of IV iron prior to the blood shortage, but actually, and in my hospital, I'm not sure that they gave more. So that's harder to measure, and it really depends what sort of systems you have in place for measuring your implementation of drugs. If you've got an electronic record system, you might be able to pull that sort of information quite easily. But again, I think probably it's difficult to necessarily say that that's related to one particular initiative. There is undoubtedly, though, an increase in IV iron use in most places, particularly perioperatively. But I don't have figures for England to show that on a national level that that's actually been demonstrated. Damien's got his hand up and may be able to tell us that in Northern Ireland he has demonstrated it.
Yes, well, we certainly over the last 10 years, the use of IV iron has increased greatly. I think as the irons became safer, as we moved away from dextran over to the more modern irons, first Venofer and then Monofer and Ferinject, the use of IV iron, people now, I think the confidence is there that it is a very, very safe thing to give, probably safer than blood. And as well, you're actually treating the underlying problem. Giving somebody a unit of blood is really only giving them a small amount of iron if they're iron deficient, compared to actually giving them, a large amount of iron to actually, keep them transfusion free for a long period of time. So yes, we have seen a very, very linear increase in the use of iron, and it just continues to increase every year as I think all our physicians and our primary care doctors begin to see more and more of the benefits of it.
That's great. Thanks, Damien. I just want to, and Andrew as well, sorry. I'll read this another question out. It's quite a good question, I think, or an interesting question at least. Someone anonymous attending, it says, our hospital is reluctant to introduce the use of emergency OD positive red cells to males and females over 50 years of age. As when we ordered our emergency transfusions, we had one case, excuse me, the question's just shifted down. We had one case of a young man in his 20s who had immune anti-D. So the question really is, how big of a barrier is the risk of hemolytic reaction to introducing the transfusions of OD positive to males and then females over the age of 50? Thought that was quite a good and interesting question. Don't know who wants to answer that one. Sorry, guys.
I think Edwin has his hand up, so probably he wants to kick start. Thank you.
I must apologise. I've had to come back on my phone. I seem to have some significant IT problems, but obviously, I mean, the issue for a man would be that the same thing happens again, that they need an OD, that they have emergency blood on more than one occasion with an unknown historic blood group. So that risk could be calculated and would be really rather small. I mean, I get there are some people who repeatedly undertake risky activities, so it's not totally negligible, but it's really that preventing the de-immunization, a key aspect of that is clearly protection for future pregnancies for the females. So, I mean, many places have certainly decided to ride that quite low risk, and it might, I suppose there could be some value in trying to calculate it and writing it in, because there have been quite a few reports that have given the probability of a female over different ages receiving a blood transfusion of D positive blood being D negative themselves, etc. So the risk to future babies, and that's been shown to be, in the order of 1 in many logs low risk. So a similar thing could be done here, because I don't think I've seen something similar for males, though others probably have.
I think Andrew's got his hand up. Thanks, Edwin.
Yeah, it was just to say that work. I don't know if someone could post this in the chat. Actually, I don't have the link on me, but Mark Yeaser, based in the States, has done some of that work around the statistical calculations, even for patients who do have immune anti-D and are exposed to D positive cells. And as Edwin's alluded to, the risk to the patient is extremely small. In fact, so small that they have moved on, again, as he alluded to calculating the risk in women of childbearing age and whether or not actually this represents a real threat to the fetus. So we could probably find that link and post it there, but suffice to say that there's been a large amount of work done on the risk, and it is really extremely small, such that if you do even have an immune anti-D that's active and detectable retrospectively, and you've been exposed to a positive blood, the risk of actually having a hemolytic reaction, and one that's of any clinical significance, is minuscule.
That's a great answer. Thank you both. I'll hand over to Vicky for the next question.
Lovely. I just see Katie have a hand up, but she popped it down again. You're sorted. Happy. Lovely.
Yeah, I was just going to say exactly what Andrew had, so it's fine. Thank you.
Fab, thank you. Following on maybe from the same topic, the next most popular one we've got is maybe saying, do we have any rationale for O positive not being used for males under 18? Is that the same? I think it's captured in that same kind of data, or is that a different kettle of fish altogether? Or is that something we want to go away and answer at a different time? I'll move on. I'll pick a less.
I think we're all waiting to bow to the expertise of the other people on the call. I mean, I would say in that we're all concerned about exposing children to risks that in adults we probably think are negligible, but clearly purely due to the life expectancy elements of it, and due to some other elements really around sort of consent, I suppose, which obviously we're not in this situation where people are giving consent here, but we're sort of taking calculated risks on people's behalf. But in a pediatric population, I think in all settings, those risks are thought to be different. I'm not saying it's the wrong thing to do, but I think it just needs a lot of thought. And suffice to say, we're still working on doing it in adults that I don't think particularly the pediatric population is a lot of low-hanging fruit. Pediatric trauma is relatively infrequent, and therefore, it's not a group that's going to save us thousands and thousands of units of O negative red cells. I don't know if anyone wants to add to that. Katie's got her hand up.
Yeah, I would just say there was a Mark Yaser again recently published a survey of pediatric trauma units and showed that very few places were using, if any, were using D-positive units for male children in this scenario, and therefore they weren't able to estimate from the available data what the sort of risk associated was. The other thing I would say, the way that we've handled this in policies is you obviously don't know sometimes when a patient comes in whether they're 14 or 17. So we have used a term which is something like males who appear to be over 18 as our sort of way of managing that in the clinical setting, because I think it is difficult because sometimes we just don't know. Thanks.
Thanks, Katie. Edwin, you've got your hand up there, please.
Just inherently to agree, really, I don't think that there's particularly, the difference between a 14-year-old and a 17-year-old or an 18-year-old makes a massive difference. But as Andy said, it's paying for gain. It's not going to make a big impact. So focus on getting it right in the older groups and then possibly consider it for the future, I guess.
That's great. Thanks, Edwin. We've got time for one more question. And this is quite an interesting question again from an anonymous attendee. And it says, why did the NHSBT move away from using learned blood transfusion? And will there be collaboration with the rest of the UK and Republic of Ireland moving forward?
Yeah, I'll take that.
Oh, thanks,
Sandra. Thank you, Si. So, learned blood transfusion was utilised software that was developed by a company called LearnPro, and their contract terms changed. So England were in a position where that was unsustainable. So it was necessary for NHSBT to find a quick and accessible solution for that for the relative short term. So we have provided an alternative learning resources for hospitals within England, but that was never intended to be the longer term plan. The plan, moving forward again, particularly from April next year, we will be working with our colleagues across the UK and the Republic of Ireland to rebuild that generic resources that we share. I did notice there was another question in the text about, is the work to share stuff and lots of these initiatives, and very much so. Increasingly, I spend, in fact, more of my time working with my colleagues around the UK and the Republic of Ireland than I probably spend on calls with people within my immediate term, because that is the direction of travel. And it makes perfect sense, doesn't it, for us to share things? Why reinvent the wheel? So absolutely, that is the way forward.
That's a great answer. Thanks, Anne. Shruti, have you time for one more question, do you think, or should we move on? One more question.
One quick question, maybe a lab one now, I think.
Yeah, for Vicky, sorry.
Lovely. I'm just having a little scan through the questions here. So maybe for Jenny, we've had one from Tony asking about rejecting pods and ONEG. How would you maybe from a lab perspective, explain about the stock needs and the different needs for people with the different options that we then provide to the emergency area?
Yeah, thank you. It looks like this question is about the safety aspects of collecting the blood from the fridges, doesn't it? That people are nervous that somebody's going to go to the fridge being asked to get the O neg and take the O pos, and then that risk of immunisation. So I think it's all about looking at your processes and making sure if you're going to introduce O pos in your fridges next to your O negs, that there's a really robust process and safe process for making sure that people pick out the right units when they go to I know a lot of people use coloured bags and they have instructions on the outside of those bags. This is for the male patients, this is for the female patients. It's things like that that we need to be looking at to make sure that the risk of error is as low as we can possibly make it.
Lovely, thank you, Jenny. I'm just going to pass over now to my colleague Emma, if she's still on the call. To help
I am,
further.
yep. Can you hear me
Lovely.
okay?
We can.
Yeah, there's two Emma Milsers. I'm the real one. I think Amy's joined with my link. So thank you for all those great questions. Apologies if we've not been able to answer them all during the session. I can see some of the panelists are still typing away there. And if you do have any burning questions, please do send them through to us at the SHOT email address, which is shot@nhsbt.nhs.uk, and we'll do our best to answer them for you. So in these last few minutes, we're just going to do a quick live poll, and we'd really appreciate you taking part. Just takes a couple of minutes. It helps us guide our future webinars and our future resources. So it's appeared on the screen there. If you choose the answers that most apply to you, the first one, how are you viewing this webinar, just guides us as to viewing patterns. To what extent did you find the session useful? What is your staff group? Just choose the closest one that you can to your staffing group. Have you downloaded the SHOT app? How useful do you find resources on the website? And based on this webinar, would you sign up to future SHOT webinars? And lastly, will you review, audit, or change your practice as a result of attending this webinar? So we really do appreciate your feedback. Thank you for that. And any comments or suggestions about haemovigilance and the work that SHOT does, we love to hear as well. So please get in touch with us by phone or by email. And visit our website, as always, same web address, it's www.shotuk.org, and on there you'll find all our reports, all our resources, and these are freely available, just as a reminder, and they can help you with your own transfusion education activities. We are regularly updating these, the videos, the SHOT bites. So again, any comments and suggestions are of course welcome. If there's something there that you feel could be improved, if there's something missing you'd like to see, please do get in touch. As I've mentioned, we have an app. So if you've not got it already, you can put SHOT UK. You have to add the UK in the search button to find the app, and that's available in Android or Apple. And keep an eye out on our website, app and Twitter for our next webinar, which will hopefully be early 2023. So keep a close eye on that. And also news should be coming out any day regarding our 2023 symposium. So hopefully you'll look out for that and be able to come and join us next year. So lastly, thank you for all your hard work submitting reports to SHOT. Obviously, and being haemovigilant yourselves, obviously without you we wouldn't be able to have events like this. So have a happy and peaceful festive period, and we will all see you in 2023. Thank you very much.